Next.
Moving ahead, we have dialectical behavior therapy, role-play based learning by Dr. Sayali Mishra, MPhil, PhD, Assistant Professor, Department of Clinical Psychology, Kalinga Institute of Medical Sciences, PBMH, Kent University. We have subject experts as Dr. Jashabant Mahapatra, HOD, Department of Clinical Psychology, MHI, Cuttack. Moderator, Dr. Pallavi Sahu, Assistant Professor, Mental Health Institute, SCB, Cuttack. And chairperson, Dr. Tanmayini Ma'am, Senior Consultant Psychiatrist and Convener, Women's Health, Section IPS. Ma'am, kindly come on stage and kindly introduce the theme to us. Please welcome her on stage with a round of applause.
Good afternoon, everybody. And we come to the end of today's session, today's workshop. I know all of you are very much engrossed in the academic enrichment, and we are very interesting discussions. Particularly, I've heard Jigyasa really very good. And I'm sure this one will be also very interesting. And I must thank Dr. Russell Urban and his team for organizing this and giving me the opportunity to share this session. And on dialectical behavior and role-play learning. And dialectical behavior therapy, what I know is a modified version. For the betterment of our day-to-day life, like focusing on the present life, and for coping stress, and for emotional regulation, and many other things. And we have to thoroughly discuss on this topic. And we have Dr. Sayali Mishra. She is already introduced by Anchor, and she is a national professor in clinical psychology in technology, and sure we had interesting discussions like the previous one. And I have a moderator, Dr. Pallavi. Good evening to all. First of all, I just wanted to know if Dr. Jashabant has joined. So, as ma'am already said, that last and the final this topic is DBT. So just we have a very wonderful speaker also, Dr. Sayali Mishra ma'am. And just before allowing her to go through the subject details, brief things that I wanted to point out. Like for every for every specialty, there is something that is very challenging. And for psychiatry, borderline personality disorder is absolutely challenging. And many reviews say that dialectical behavior therapy is often used to say about the dialectical behavior therapy being one of the treatment of choice for borderline personality disorders.
And when I say it is challenging, we need to understand that one of the things that my senior always used to remind me while I was doing the post-graduation, that a case of borderline personality disorder will teach you psychiatry. It will teach you psychology, it will teach you dissociation, it will teach you interpersonal therapy, it will teach you a teamwork. So as DBT also deals with a teamwork, and if anybody says that I treated a borderline personality disorder, I will definitely not believe you, because it always needs a teamwork. And for that, Madam is the expert, and I welcome Madam to the stage.
So can you start for everyone? Everything okay? Start for everyone. Slide sharing for slide start for everyone. Okay, coach. Next time for so everything start for you.
Thank you, ma'am. Thank you, respected chairperson. Thank you, moderator. Thanks for the crisp introduction. Welcome all my respected faculties, seniors, my dear colleagues, and students. So today my topic is dialectical behavior therapy. So before I start my presentation, I just want to share a very short story with you of a woman called Marsha. During 1970s, Marsha was diagnosed as having borderline personality disorder. And unfortunately, that time there was no robust therapy format to deal or to treat this kind of disorders. So she was heavily medicated, and she suffered a lot during that time. So during 1990s, in her doctoral work, she developed this module called dialectical behavior therapy. So the founder of the therapy is Marsha Linehan. The therapy was developed during 1990s, and today this is the gold standard to treat borderline personality disorders. So in the lines of Marsha herself, borderline individuals are the psychological equivalent of third-degree burn patients. They simply have, so to speak, no emotional skin. Even the slightest touch or movement can create immense suffering. So we can just imagine how much suffering they would be going through. So before we move on to the basic concepts or the techniques of this therapy, we would like to understand what does dialectic means, because behavior therapy is very common. It is after CBT, the DBT has come. But what does dialectic means for us? So all of you can able to see a picture on the screen, right? So what are your responses? What do you see on the screen? Okay, someone says two faces. Anything else? Okay, a vase, a black vase. Okay, so now how to decide which response is correct? Both are correct, right? So that is what dialectics exactly means. Okay, so there are two opposing things can coexist in a particular situation, a particular event, a particular thought. So this is what basically dialectics talk about. So as we just talked, that Marsha Linehan in 1993, she developed and wrote a manual, a very systematic manual with a lot of worksheets she has written. It was the basis of this therapy is from the orientation from systemic and transactional approach
from CBT, Zen, Buddhism, and principles of dialectics. So we can see a lot of Eastern influence on the philosophy of this therapy. It was developed mainly for the use with persons with borderline personality, of course, but mainly with to treat with the suicidality in these patients, all the self-harm behaviors in these patients, and also for the adolescents with eating disorders. Some of the basic principles of the dialectics that just now we saw that two opposing things or two forces can coexist in one particular event. That dialectic talks about. All things are interconnected. The change is constant and inevitable in the life. And there are different perceptions of the same event which is possible. As right now, one picture was shown and there were two responses. So an event or any particular situation can be seen or viewed with different perspectives. So I know the topic is dialectical behavior therapy. So we are not going to describe more of borderline personality disorder, but basically, as I mentioned, this is the gold standard therapy to treat the patients with borderline personality. We have to know certain things about borderline personality also. So Linhan's theory of borderline personality is basically based on the biosocial theory, which you must all be knowing about. There is already an emotional or any other vulnerability in the person. Along with that, there is an invalidating environment. And when the both things are combined, it gives rise to the problems or the formation of various symptoms like emotional dysregulation or interpersonal conflicts or distress tolerance problem. So I would like to take forward this discussion from a case conceptualization point of view. So you all are mental health professionals. Some of you are trainees. So in your OPDs and IDs, you must be seeing many borderline personality disorders nowadays. So I'll be just narrating a case of a borderline personality disorder. I'm sure most of the things you may find very familiar. So a 24-year-old female who came to our OPD with her parents with recent self-harm attempt, with other complaints of crying spells, emotional outbursts, difficulty to carry out her job in an IT sector, severe interpersonal problems at home, work, and friends. The characteristic features which we found in the case were severe mood swings, poor frustration tolerance, frequent attempts of intentional self-harm. There was a history of childhood sexual abuse, inability to maintain long-term interpersonal relations, low frustration tolerance, impulsive decision-making, recent relationship breakups, chronic feeling of emptiness, occasional alcohol and drug use, and poor compliance on treatment. I'm sure this kind of a person or this kind of a patient must have appeared in front of you after discussing all these symptoms. Now, when we take forward this patient through the therapy, okay, there are certain stages or there are certain modes of DBT. So these modes are individual therapy, skills training, there are phone calls which are included, crisis therapy, and certain ancillary therapies. So during the stages of therapy, broadly we can say that there are 4 stages of DBT when we carry out. In the initial couple of sessions, we carry out the assessment as we do in CBT. We do in CBT a kind of ABC analysis, the antecedents, behaviors, problem behaviors, and the consequences. That kind of analysis is also done before DBT. So stage 1 after assessment focuses on the suicidality or intentional self-harm behaviors or the behaviors which are interfering in therapy. Stage 2 focuses on more of trauma-related or PTSD-related problems. Stage 3 would be more about improving self-esteem and attaining individual treatment goals. And stage 4 would be skills generalization or overall improving the meaning in that patient's life. So as I said, stage 1 is life-threatening behaviors. We deal with those behaviors. Stage 2 is more we deal with the trauma. Stage 3, it is more to regulate the emotional balance. And stage 4 is the other psychological factors like dealing with incompleteness and boredom. So when we carry out the individual therapy, usually they have suggested that there is once weekly individual therapy session, whenever needed phone calls, and a group therapy session. So individual therapy first focuses on the behavioral targets, diary cards, chain analysis, and developing commitments. So there are two types of behavioral targets we focus on. The primary goals or the primary targets are self-harm behaviors, therapy interfering behaviors, and quality of life interfering behaviors. So self-harm behaviors which are very evident with which the patient has come to us. Therapy interfering behavior, can anyone tell me what it would be? You must have experienced certain therapy interfering behaviors. Yes, or cancelling the appointments, coming late for the therapy session, not paying to the therapist. So all these are therapy interfering behaviors. Quality of life affecting behaviors would be like very commonly you must have seen borderline personality patients. They have very erratic lifestyle, very erratic sleep-wake pattern, erratic eating pattern, indulgence in substance use behaviors, reckless sexual practices. So these all come under quality of life affecting behaviors. Because as if there are parents or other family members who are accompanying this borderline person, they would tell you that, madam, whatever or sir, whatever you do, first you have to treat this self-harm thing, and then you have to look into this problematic behaviors. That this person sleeps off at any time in the night at 3 a.m., 4 a.m. and wakes up at 12 p.m., 1 p.m. like that. She doesn't eat at home. So certain things like that. So we have to have a list of targets in which way we are going to deal with these targets in the therapy session. The secondary goals are more, I must say, philosophical maybe, or they are real dialectical dilemma or the secondary goals of these therapy patients. First goal talks about the apparent competence versus active passivity. What is that? Apparent competence means few patients or few patients will pose to you as if they are competent to handle all their life crises. They don't need you. They don't need any therapy. Versus active passivity. There are over-dependent clients. They will ping you, they will message, keep on messaging you, this happened, that happened. They will cry, they will always call you. So this kind of a dilemma is there. Second group is inhibited grieving versus unrelenting crisis. Grieving here is not related to grief or that mourning, but it is like extreme emotionality. So inhibited grieving is inhibited emotionality. They are unable to express themselves in emotional manner. They appear very practical in the therapy situations. They are just concerned what are the fees, how much time I need to be there. They may call this therapy as a class, DBT class ke liye kab aana hai. It is like that. Versus unrelenting crisis. Like some patients you will see they are always crying. They just need your shoulder all 24/7 to cry. Okay. Third one will be emotional vulnerability versus self-invalidation. So some patients are emotionally very vulnerable. They have very low frustration tolerance. So even as a therapist, when you are using your words, phrases in the therapy session itself, one has to be very careful how you are phrasing your words, how you are giving examples, using of metaphors or worksheets. This is very important in case of this group of people. Versus self-invalidation. That is, few patients just they invalidate their own thoughts or feelings like that. So moving ahead in this therapy, as I told that when we conduct CBT, we usually have... hello? Please mute your mics. Someone is doing supportive therapy on Zoom. Okay. Fine. So coming to the behavioral chain analysis. So this is very, it is the equivalent of the ABC analysis we do in CBT therapy. So it talks about the vulnerabilities. What are the vulnerabilities of the client? Then triggering events. As we talk about the precipitating, perpetuating, maintaining factors, like that, the triggering events, links, cognitions, and feelings. Then what are the unskillful behaviors which the client is showing, and what are the ultimate consequences of the symptoms. So the diary cards are equivalent of thought diary or thought logs, which we ask in CBT. So it includes the incidents of behavioral targets or just to engage in behaviors or use of substances, use of practice skills, and rewards to the client. Improving commitment in the therapy. Now, this is very important point where therapist has to be very clear that it is not the responsibility of the therapist to engage the patient into the whole therapy process continuously. The client has to take on the responsibility of his own change. And that is very important to prepare the client in first few sessions by discussing about the pros and cons of not engaging in therapy fully. So it is again completely a collaborative therapy approach as we do in CBT. It is not a directive form of therapy. With these things, we can improve the individual commitment of the client in the therapy process. This is the example of a diary card. Now comes the very important part of the therapy, that is skills training module. So there are 4 skills training modules in DBT. First talks about the distress tolerance skills. Second one is mindfulness skills. Third one is emotional regulation skills, and then the interpersonal effectiveness skills. So there are various different techniques, various behavioral techniques. Why DBT is nowadays very popular as a third wave therapy? Because it can be used even in adult and adolescent population. There are a lot of behavioral techniques which you can actually explain this to client in very simple formats. So talking about the distress tolerance skills, these are also called as crisis survival skills, because when in the initial part of the therapy, the client has come with maybe all the those slashes on the forearms and repeated attempts of self-harm and substance abuse behaviors. So we need to improve, we need to reduce this particular behavior and improve the quality of life. So first skills talks about stop skill. That means S stands for stop. Then take a step back. Like we explain the client that whenever you have to act on an impulse, you have to stop for a moment, take a step back rather than acting on it immediately. observe around, observe your surrounding, and then proceed mindfully. Then comes the tip technique, that is the acronym. T stands for tip the temperature. Like we explain the client that whenever there are very acute urges and very strong emotional changes in you, even though there are certain physiological changes also in the body, and the body temperature also goes up. So to reduce the temperature, we ask the client to tip the fingertips in the ice cold packs, or hold the ice cans, or hold chilled bottles. Then comes the intense exercise. After doing that, the client can switch on to intense exercise. Then paced breathing, that is a regulated deep breathing and progressive muscle relaxation. So this tip talks about all these four formats. Then we explain them about the pros and cons of acting on impulse or on not acting on the impulse. So what is the benefit or what is the disadvantage? Then comes the technique called as improve. Okay, again it is an acronym. I stands for imagery. So we all use imagery up to certain extent in even in CBT format also. So in imagery, this is called as a safe place visualization, where we ask the patient beforehand, the client beforehand, what is the safe place for the patient, that person, emotionally, physically, a very safe place where the patient finds himself very calm and relaxed. So you get the description from the patient, and ask, like, visually you have to, it will be like a guided imagery where you are guiding the patient to be in that safe place in his imagination. Then comes meaning, that is providing meaning even in any negative situation. Like we explained that jo hota hai achhe ke liye hota hai, there is a saying like that. So why it is said like that? So can you find something good in whatever happened or whatever stressful situation arise in your life? Or prayer. Prayer is not related to any religious or spiritual connotation. It is like just inviting your own internal emotional resources for your utilization. Then relaxation, one thing at a time. Now, just now Dr. Jigyasa had a session on ACT where she had started the discussion on mindfulness, and mindfulness is a core component of DBT also. So even from the skills of distress tolerance itself, we try to teach the client how to be mindful. So how to do one thing at a time. So in today's era, it is very difficult even for us. We all are multitaskers. We do so many things at one point of time, and that increases a lot of stress in our mind. So one thing at a time. Then vacation. It doesn't literally mean that packing your bags and going somewhere after every stressful situation. It's not like that. But just taking a break for some time from your routine job or activities and be away from that job for say a day or two. And encouragement, encouraging your own efforts, acknowledging and encouraging your own efforts you have put in the name of the change. So there are other radical acceptance skills or reality acceptance skills also. There are so many different minute skills in the distress tolerance, because this first module itself is very important for any borderline personality or eating disorder client. So it also talks about certain distraction skills, self-soothing skills. So we ask the person to find out certain self-soothing activities, maybe some sensory activities which he can find very soothing. It also talks about half smile, willing hands, and mindfulness of current thought. Now, we have made a video, a pre-recorded video on some of these techniques. So where we have made a role play between myself and Shivani, where I have played a therapist and she as a borderline client. And some of the techniques we have tried to discuss in that video. So later on, we just complete this module and switch on to video. Also, we talk about the different coping styles, comparing these coping styles, cue-controlled relaxation, connecting with your higher values of life, using self-affirming or positive statements. And then we ask the patient to finally create an emergency coping plan. So what we do is that, like I have brought some of the reminder cards like this. So we usually prepare these cards which talk about different techniques in the module, which we are actually addressing in the therapy session. And the client carries this card back to the home and works on it, because there are various worksheets also nowadays available on DBT format. So, but we can't bombard the patient with a lot of worksheets. So you give them certain reminder cards and ask them to make a list of these some techniques and what is most appropriate for the patient. There is no generalization. It is not that you are prescribing ki distraction ke liye ye karo or you do this for self-soothing. It is not like that. It is up to the individual client for according to his own wishes, he can make a plan, his own emergency coping plan. Now we can play on the video.
Hello ma'am, I'm okay. Good.
Please excuse us for the sound. You have to be really mindful to
Just a fight with a friend. I mean,
hear
we blocked
this.
each other. He said some very harsh words because I was trying to overreact probably, and I also said really bad things in return. So now,
Volume.
what am I doing?
So, do you face this kind of situations quite often?
Yes, it keeps happening when I don't get an instant text reply, when I have some expectations from people, from in the family also. I end up getting angry so quickly that I just don't know what I do after that. Sometimes I end up eating too much, sometimes I'm smoking, sometimes I'm doing things to my body. And the things I did with my body earlier, that has come down, but then smoking and eating has started like being an alternative of that.
Oh, okay. So that must be very troublesome, right?
Yes, I have stopped meeting my friends also because they all keep lecturing me about how I shouldn't smoke or how I should take care of myself more often. They are right, but lecture, so much lecture that I just know that I need to fix something, but somehow talking to them is so difficult.
Okay, so you understand that there is some problem, but you don't find a way out, right? How to fix up these problems?
Yes.
Right. So we need to talk about certain techniques, maybe, so which can help you to overcome your distress whenever these kind of problems come in your life, even maybe on daily basis. So we need to have certain skills with us, right? Do you agree?
Yes, ma'am.
So these skills are called as distress tolerance skills, Neha. You can also call this even crisis intervention also, right? So whenever there is such an acute emotional outburst, when you feel very angry, very irritated, and you feel like maybe slashing your forearm or doing something to yourself or overeating. So that is the time when you can take the help of these things. Okay. So the first thing which I want to tell you would be related to imagination. Okay. It is called as imagery, a safe place imagination. Okay. So can you tell me something about a place where you find yourself very safe and very happy, peaceful?
I think it's when I'm in my room. There is, like, on the top floor of my house, there is only one room.
Okay.
And once I close the door, there is nobody to disturb me. It's very calm.
Okay.
And I don't even start playing the TV or anything. So it's very, very quiet there.
Okay, so that is one place where you find yourself really comfortable.
Yes.
Right?
Yes.
So we'll call this place as your safe place. Okay? So quickly we will do one small exercise. Right? Are you ready? Be comfortable in your chair. Okay? Just close your eyes. Now we have to focus on our breathing. Just take a deep breath, hold it, and then slowly you can relax. Again, take a deep breath, hold it for a second, and then release the breath. Yes, very good. Just focus on your breathing, the way your breath is going inside and the way you are exhaling the breath outside. Maybe initially it will be little difficult, but with the practice you will be able to do this. So now, while you are focusing on your breath, I will just describe about this safe place to you. Try to imagine that in front of your eyes. This is your room. Now you open the door of your room. You have entered the room and now you are there alone in your room. You feel really happy and comfortable in this room. Try to figure out what all things are there around you in this room. Just focus on each of those things. How is the temperature of your room?
It's cozy and warm.
Okay. What is the color of the walls?
It's white.
Okay. Okay. Which kind of curtains are there? What color is that?
I really picked up the base green color curtains.
Okay. So now you have sat down on one of your favorite places in your room. You find it really comfortable when you are there. Most of the thoughts, most of the negative thoughts, impulses, even if they come to your mind at this place, somehow the surrounding, the environment of this room makes you feel very comfortable and you don't feel like acting on it immediately. Try to feel that environment again in your room. Be relaxed. Relax. Okay, now you can slowly open your eyes. So, how was it there?
It felt like when I'm angry or I'm feeling distressed, there is something building up back at the back of my neck. But when I was doing this particular activity, it felt like that particular thing flowing down back.
Yes.
And it felt excellent.
Okay, that's
while
great. That's
it
great.
was happening.
So that shows also that you are good at imagination, right? You can use vivid imagery when you want to relax yourself. Okay, so this is a kind of a tool in your hand now. So henceforth, whenever you feel very anxious or very irritable, very angry, you can use this imagery. Okay.
Yes.
There are certain other techniques. Few of them we will do it right now. Okay. One more thing is called as willing hands. Okay. So this definitely DBT must have inculcated this technique from Eastern philosophy, from our yogic literature, because as you know that in our philosophy we say that clenching of clasping or clenching of hands and fists doesn't give much of positive energy, right? So
we mostly do it when we are irritable or anxious.
Yes, or we want to withdraw from a particular place. So now here what we want to do is we will keep the hands, our palms on this table like this in a very comfortable position. Okay, in a relaxed state. The fingers are very relaxed. Okay, and the thumbs are like in an upward position. So the fingers are and the palms are facing upwards. And just you are keeping it very much relaxed. Okay. Maybe at this time you can even use one another technique called as prayer. Okay. So this prayer is nothing to do with any religious or spiritual belief. It is just you are inviting your own emotional energy, your own internal energy to work with at that time of distress. So whatever resources, inner resources you have, you are inviting those resources to be with you at that time. Okay? So you can use this particular technique and keep your hands and forearms completely relaxed just for 2 to 3 minutes. So this is one more technique you can use. Okay. Okay? Very good.
I feel good when I'm even doing this, and I'm thinking that okay, if I sit like this while praying, it'll feel better.
Okay, that's good. Yes. Okay. So then one more technique the DBT has talked about is called as half smile. Okay. So it is very interesting. You must have seen the portrait of Mona Lisa, right?
Yes, ma'am.
So how is her smile?
Like she's not exactly smiling, but it seems like she's smiling.
Yes. Okay. So it's not a very broad smile she's wearing, right?
Yes.
So it's a very short kind of a smile. So see, you must have observed yourself when you are very irritated and angry. Okay? You are putting a lot of pressure on your facial muscles also, right? So here what we are going to do, just to distract from that irritated mood, we have to relax these facial muscles. And for that they are saying that just to carry a half smile on your face. Just a little bit of smile on your face. Even if there is a lot of anger.
Right now also you can all do that half smile. Even if you are bored.
Instead of right now working on that anger, you are just carrying the half smile and sitting like this for another 2-3 minutes. Okay. With the practice you will be able to understand that it has an ability to change your mood up to a certain extent. Okay. See, whatever techniques we are right now discussing, maybe it may happen that all of them you are not going to carry out in your daily practice. Okay? But if you know certain techniques, then definitely it will be very easy for you to carry out.
Yes, this looks workable. This is something that I can do.
Yes, so it is. These are all very much behavioral strategies. Okay, you are not working on a thought level actually, right? So these are certain basic techniques we can say here. So there are other distress tolerance techniques also. So I have made certain reminder cards, okay, for your. So I will be sharing you this one.
This one. Some of the techniques which we saw from the distress tolerance. See, one thing is that it is not very easy. This DBT whole module or all the 4 modules take at least 6 months to 1 year for a client. Okay, so we are condensing most of the things within 45 minutes. Okay? So whatever you are listening or seeing are some of the glimpses of those modules. You can see a picture in front of you on the screen. Now, as you must have understood that we are going to talk about the mindfulness module now. Okay? What is mindfulness? According to our Eastern philosophies or DBT, the root cause of all psychological problems is that the mind wanders either into the past or into the future. It runs into the future. But it is very difficult for us to concentrate on the present moment, in here and now, at present. And that is usually the cause of all the distress or the psychological problems. And so that is why DBT gives a lot of preference on mindfulness modules. So in mindfulness modules nowadays, you can see there are many workshops mushrooming around us. Mindfulness breathing, mindfulness eating, walking, everything mindfulness. So in the DBT format, we usually start with mindfulness breathing techniques. We train the client in some sessions about the mindfulness format. The DBT also talks about the wise mind meditation, or what is my wise mind. So DBT says that we have 2 different aspects in our mind. One is emotional and one is rational mind. And a wise mind is the bridge between both these minds. Okay. So this is the aspect of our mind which everyone has, which is usually used in the mindfulness formats. So there are again certain small techniques which we use. For example, interesting thing like thought diffusion, which we can also use with adolescent patient. For example, when the person comes to us saying that there are a lot of negative thoughts and distressing thought coming into my mind, how to deal with those thoughts. So some of the behavioral things which DBT says that use of imagery in thought diffusion. So how can we do that? We can make use of any analogy. For example, ask the client to just keep calm, close the eyes, concentrate first on the deep breathing, and then ask the client to vividly imagine the sky full of clouds. Okay, and the therapists say that now whatever disturbing thought which is coming to your mind, distressing thought, just imagine that thought riding over that cloud and drifting away from your mind. It is taking that That cloud is taking that thought away from your mind. So some of these techniques we actually do in the therapy situation, even for the cognitive, emotional, even in CBT also some of the techniques which we used to do. But going a step ahead in DBT, there are so many formats for thought diffusion. So mindfulness mainly talks about the what skills and how skills. So what skills are observing, describing, participating, both inside and outside of. So for example, if I now ask you to just close your eyes, concentrate on your breathing, and then just the inner mechanisms of our body. For example, just pay attention to how my breathing is happening. Then what is my current thought right now at the moment? How do I feel? What is my emotion at this point of time? So paying a lot of attention to your inner mechanisms, as well as same thing we can do with the outside world. For example, when the client comes, we ask them to sit comfortably in the therapy room, and then after closing the eyes, describing about a particular object which they saw in the therapy room, or about the participating thing, like describing a particular action. Say, for example, you are singing a song, you're dancing right now. So the aspects of that activity you have to actually experience during that point of time. So these are the what skills according to DBT, and how skills are done in non-judgmental manner, open mindfulness manner, and effectively. Obviously, when you become mindful, you are non-judgmental. You are just accepting the things as they are coming in. Your mind is open for all the, even if it is a negative thought, it is open. Even if it is a positive thought or emotion, it is open. You are not judgmental about what should come in my mind and what should go, and it has to happen effectively. So all these things you can imagine that actually we are doing in a therapy situation. Next module talks about the emotional regulation, which is about, there are again certain techniques in emotional regulation. First techniques talk about ABC, please. It's an acronym about accumulate the positive emotions, building mastery about the talents, coping ahead, treating a physical illness, eating balanced diet, avoiding addictions, getting adequate sleep, and exercising. Then acting on opposite action, checking the facts about the situation. Like DBT talks that whatever situation or whatever environment it appears to you, it may not be the exact way. It may be your perception and your biases are coming in. So just checking the facts of the situation, understanding, we train the clients to understand and name the situation of their own and others, and clarify misconception. Like, for example, in REBT, you must have learned that we talk about some shoulds and haves and musts. So we all have these notions in our mind fixed. For example, when a client comes to you and tells that I had a relationship breakup last week. So we assume that the client must be very sad. But what if she has come out of a very toxic relationship? Then maybe she is actually relieved. She must be feeling the sense of relief rather than being very sorry for that exit. So there should not be any preconceived bias or misconceptions about other person's emotions. One more thing is that our emotions are colored with our physical sensations also. For example, at times now all of you, like I can see the faces, like it is too much of cognitive bombardment which has happened in the last 4 hours. So I can't really predict with 100% accuracy who is feeling what, right? So that emotion is colored with many cognitive and physical factors. Thank God that Dr. Russell sir just now gave tea and snacks to all of you, so that some physical relief is there. But otherwise, if you are so tired, if you are hungry, thirsty, then all these things color your emotions also. So we can't predict 100% that whatever we see on the person's face is 100% right. The real emotion could be hidden. Next comes the interpersonal skill, interpersonal effectiveness skills. It talks about how to locate the toxic relationships, the risk involved in these relationships, the interpersonal blocks in that relationships, and knowing exactly what you want. So DBT talks about, again, one acronym called as DEAR MAN. That is describe, express, assert, and reinforce. Describe what you want exactly in the relationship, which we lack actually. We lack the interaction in any, even relationship like boyfriend, girlfriend, husband, wife, brother, sister, parent, child. Whether do we really describe, whether do we take the responsibility that yes, I want this from you. I like that if you say this thing to me, I feel very happy. So describing that, expressing it rightly, asserting your needs, and reinforcing other person's action. Then mindfulness, again in this interpersonal relationships, appearing confident when you are putting your needs across and negotiating well. One more acronym talks about GIVE, that is be gentle, because even in any therapy, when the client comes in, the first rule is that there should not be any physical, verbal abuse or violence involved in any kind of relationship. So it has to be very gentle. Act interested, validate each other's emotions and thoughts, and easygoing. Then comes FAST. It is again the acronym of be fair, don't over apologize, stick to your values, and truthful. So it is kind of a learning in assertiveness, we can say. So certain other ancillary treatments which we were talking about. So this is the usual format of an individual therapy session, which goes on for at least 6 months to 8 months for one client. Along with that, some phone calls, vocational and educational support, and group therapy, which goes for 2 hours weekly for 6 months by a trained therapist. Then one more concept I found in the handbooks of and manuals of DBT, which is very interesting and which is totally missing in our society, is support for therapists. That is therapy for therapists. We don't have that, right? For example, doing this intensive therapy, CBT, DBT, SCT, anything, it is very exhausting. It is emotionally draining even for the therapist also. Okay. But we don't, as a therapist, we don't have any platform, or we don't go to each other to seek professional help. We don't have discussion forums where we discuss difficult cases to each other, okay, or seek other person's advice. So this is done abroad quite regularly. So I thought that we can introduce this particular concept in our society. Again, in a very non-judgmental and open manner, then it will take care of our own mental health also. And crisis intervention, that whenever it is not that only in initial stages the patient will come with slashes on the hand and with intentional self-harm and other things. Maybe during the therapy there are certain triggers, and if the patient comes with any acute crisis, then you should have a medical team along with you, and whenever needed, hospitalization for the patient. So the research and RCTs in DBT have shown that it is very effective in borderline personality disorders, substance use, mood disorders, eating disorder, dealing with trauma, PTSD, and suicidal behaviors. These are some of my recommended readings. I have mainly referred to line hand manuals, the worksheet manuals, and Mackey et al. Manual for this. Thank you. Hello, we have Dr. Seema Parija with us. So we welcome her, and we would like to have her remarks on the session.
So, good evening, everyone. Thank you, Sayali ma'am, for this wonderful presentation. It is really nice to see you. Thank you to the organizing team to give me this opportunity to talk about this wonderful, listen to this wonderful topic of DBT. Actually, if I may, that all the three topics chosen today are interlinked with each other. Though each of the therapy, it deals with a particular disorder, but if we go, the MET is about change talk. And in DBT also, we want certain things to change. When we are talking about acceptance and commitment therapy, yes, it also deals with the accepting certain things and like mindfulness. So when we are talking about DBT, so what ma'am has described very nicely about emotional regulation and about distress tolerance, the modules of mindfulness and interpersonal effectiveness. It is really, really nice, ma'am. Only thing is that we psychiatrists, we always come across patients with borderline personality disorder, and we are at a fix at one point or another. So as madam told about this is a very intensive therapy. It's not something which can be done by all. And about certain mnemonics which you told about improve is really, really nice, because improve will definitely improve the moment, and the moment will definitely pass for others. And what madam told about half smile, I can see the half smiles turning into the full smiles in the audience as well. So I wanted to just ask madam about this, like how do they follow up about the, like this therapy is such an intensive therapy that about 1 hour per session, 1 to 2 hours, along with group session of 1 to 2 hours per week, and that goes for at least 6 months to about 1 year. So what is your experience, madam, with the clients?
Yes, she has asked a very valid question because it is very exhausting for the therapist herself. So what about the patient? So it is a challenge to hold the patient into the therapy process. That is a really big challenge. But yes, when we actually practice this therapy, we usually advocate that we follow the manualized therapy process, that we follow these modules as it is written. We usually start with the distress tolerance module, and then we later on we take on the other things. Definitely the priority of the goals and the modules changes according to the person, individual, the patient. But yes, there are quite a many patients who are there regularly coming for the therapy, DBT, and but we actually miss on the group format most of the times. It is not very easy, even though we all know that nowadays we are getting so many borderline personality patients, which was not there earlier. But this is very missing in our clinical practice, that hardly we have these groups of these patients. Okay, so we miss on the group format, but individual therapy once in a week that we usually carry on and try to improve the commitment of the patient as far as possible.
Thank you, ma'am. In this, I would just like to add, actually the borderline traits and the patients, they were always there. Actually, what we do in our clinical practice, we focus on the axis 1 disorders, and somehow we forget about the personality part, and in which which is a certain thing that definitely we would like our trainees to address. I can see Dr. Jaswanto sir is also there. Sir.
Good evening, sir. Welcome to the session. Your comments, please.
Thank you. Thank you, the organizers, for inviting me to this beautiful day. But I was not fortunate enough to be present physically. Anyway, I enjoyed for the last 2 to 3 hours. And what a coincidence it is when the entire world is going through the third phase. Our Dr. Sayali is also rescuing us with the third wave therapy, that is DBT. See, it is proved to be effective in many of the conditions what she has narrated, and the skills she has taught. See, it appears very easy, it appears very simple, but until and unless we practice it, we will not succeed. So let us practice this with ourselves first. Let us understand our emotions, and then we'll apply it on the clients. Thank you. It was a beautiful 3 sessions I have enjoyed. Thank you very much.
Thank you, sir. Thank you, Dr. Seema.
Thank you all for joining. Thank you, Dr. Sayali, for this wonderful presentation. Thank you, Dr. Jaswanto. I know you're not well, but you're still trying with us. Thank you, Dr. Seema, for trying. And it is still opening going on in the cell, and she managed to join with us. Before ending up, I just wanted to say that there are certain things with DBT and about borderline personality disorder. One, when you open the book CTP, the first line it mentions that it was developed to treat female patients having borderline personality disorder. So that female word was really, when last night I was going through it, it really hurt me at some point or other that why was that word written as a female? Okay, maybe with certain years, after some years, maybe this, this thing will get, they're not be confined to only to female, there are only female borderline personality disorders. There are also some male borderline disorders. And the overdiagnosis of borderline personality disorders that has been happening rampantly. And another thing which I initially emphasized is because Madam also said, because it needs a team. You cannot deal with the patient alone. It's exhausting. I'll tell you, I'm from a very small institute. I'm not working in big institutes, but I've worked in a very small institute. While I was doing my post-graduation, the first day when I entered to the department, I was told to go to a MM class. I was really surprised what was the MM class. I worked in an institute which was in Gujarat, so people were speaking Gujarati. And when I entered the room, I saw everyone in the department was working with us. Some of them I have not been introduced. They were sitting in a round chair. It was a round table conference kind of thing. No tables at all, only chairs. In a very calm and composed manner. Even the HOD was sitting in a palki position in the chair. And they were discussing their thoughts, their emotions, whatever they were distressed with, their own day-to-day, troubles, interpersonal issues with their colleagues, with their seniors, patients, whatever had happened in the OPD. And it used to happen in a very non-judgmental way. We never used to judge anything. We just allowed them to talk. It was free space for us.
And such kind of thing, I think after coming out from there, I've worked in many institutes. I'll tell you, I've worked in all the institutes in Bhubaneswar, and I'm currently working in 2 institutes in Cuttack. I've not found any of these institutes, getting that model into it. And mind management. it was coined by some seniors, and it has been running there. And after coming in from there, I really missed that thing. And every year, once in a year, we used to have admin. Since I'm working 5 hours away from Gujarat, so it was very difficult to go over there. But this concept was really wonderful because, when you're working in such a big department, you will never have good terms with everyone. You will have some tussles, you will have some problems with patients. And this kind of platform really eases you. It gives you a platform to express yourself. And at times we learn from their mistakes also. At times we learn that, someone else is going through the same problems also. Somebody else is having the same problem with his patient or her patient also. So all these things are really wonderful experiences. And I hope in future, maybe departments everywhere have some amount of time in a week, at least 15-20 minutes in a week, they can sit down. Even at the time of COVID, when people were going through such a kind of stressful work environment, everybody was complaining, I'm very stressed out and burned out, all those things. But, this could have helped someone or other everywhere. But hope, there's always a hope that our coming years, maybe we can have such kind of, units in every department, medical colleges, in every department. That's all from my side.
Thank you, Dr. Sayali. Actually, you presented this systematically and it added to our knowledge actually to also clinical practice. One thing I would like to tell you that I've been in practice for many years, and most difficult for an idea is to treat a borderline. The moment I know that is a borderline, I don't want to be like that. Sometimes I get that feeling instead of treating being a practitioner. I don't want to treat a rather excellent. So, like what I want to ask you that if it is for taking borderline personality disorder as a problematic role, that is the whole theme of course, I do agree with the whole thing. But in your practice, like personally, how much successfully you are in treating? I mean, how much result, how much successfully you measure? Like your personal experience.
Yes, actually, I would like to say that, see, why we all are repulsive towards borderline personality disorder, because there are otherwise also there's so much of psychological mechanism involved in therapy process itself. Within the therapist and the patient also, as the therapy goes on, there is those borderline cognitions start coming in, splitting, projection, all that towards therapists. So it becomes really overwhelming for the therapist to handle those situations. So as far as I have mentioned about the first 2 modules, like distress tolerance and working with the mindfulness. So definitely we feel happy when we are at that stage. Like, with distress tolerance and mindfulness, it shows a lot of success according to my personal experience, because lot of behavioral, we can say, experiments, we can actually engage the patient in the therapy, which was little absent in CPT format. It was more on the cognitive errors and distortions in schema and all that, whereas in DBT, it is more behavioral. So now it is almost 70–80% we can engage the patient in first 2 modules. But as we proceed further and go towards the core issues, which I was talking about, the secondary, the more dialectical dilemmas, we can say. So we are actually touching their personality cores. So that is the point where मतलब दोनों हिल जाते हैं, therapist भी और patient भी. So that is the point where therapist has to be very steady and stable. That there the therapist personality comes into picture. If the therapist also has certain emotionally unstable traits, then it will disturb the whole scenario. But then we have to involve, as all of us are saying, other professionals, family members of the patient who are little better to deal with those things. So during the third stage of the therapy, I think it becomes little difficult. And patients with who are having very severe trauma history. Yeah. No, you can get it online by Linhan, and by Mackay you can get the worksheet manual also.
I think I want to close.
Thank you, ma'am. It was really informative, and I know how elaborate DBT can possibly be and how we have tried to sum it up in one PPT and within limited time. And I would like to call on the stage Dr. B.R. Mishra to felicitate Tanmayani ma'am and Pallavi ma'am. Last round of applause, please.
प्रेसिडेंट को पाई आश्चर्य से कोविड हॉस्पिटल आपन को
प्रेसिडेंट को तो नहीं जब सर सब जाक धरि के बेसले सर लास्ट रे कहबा
प्रेसिडेंट आश्चर्य कोविड हॉस्पिटल
हे भगवान सर
अनुपम आजा हम से जो बस टीम रो नथिला जोटा बैनर देलो बैनर ता जोटा मझरे ब्रेक वाले लागिला
We request all of you to please kindly join us on stage for a group photograph. All of you, yeah, please join us for a group photograph. Santuna and friend, please come.
प्रिंसिपल करिया तुम दे दे बहुत ओजनिया वाला तो हां रेडी फोटो उठे दियंती के हमर ए ना सर कोविड मास्क सर आपण बीजेपी से राजी को चिनी करना दीजिए इधर को फेरी गले